Hello, everyone, and welcome to Health for the World's International Grand Rounds. Thank you so much for being with us on today. We are in for a treat today from the world of cardiology and are joined by Dr. Michael Givertz. Dr. Givertz attained his medical degree from Harvard Medical School in Boston and then went on to complete a residency in internal medicine at Brigham and Women's Hospital. Afterwards, he pursued fellowship in cardiovascular disease and also in advanced heart failure, also at the same institution. He has now become a renowned advanced heart failure specialist. He is actually the medical director of heart transplant and mechanical circulatory support program at Brigham and Women's. And in addition to his clinical interest, he has become a prolific author and researcher, and he has collaborated quite closely with the NIH. Dr. Givertz, we are very, very lucky and incredibly grateful to have you with us today, and you may begin whenever you are ready.
Great. Well, thank you so much. It's really exciting to have this opportunity. And I guess I wasn't sure if I should say good morning, good afternoon, or good evening. Hopefully there are folks listening in from all different time zones. But it's great to be here. So, my passion is really managing patients with heart failure and advanced heart disease. And I thought I would spend time today with you talking about advanced heart failure and heart transplant, where we are currently, but also a little bit where we've come from and where we're going. So that's the title of my talk. I will say this is an international story, although it will highlight more of some national data as well as we move along. I have just some disclosures listed here. I have some research funding, and I will be discussing briefly some off-label investigational medication use, but I will not discuss another really primary area of focus for physicians such as myself, which is cardiogenic shock or use of shock teams. And I won't be talking at all about really the temporary or use of temporary or durable mechanical circulatory support. That's really for another time. So, heart failure, I think, as everyone knows, regardless of where you are within your training or in the healthcare field, is a growing problem. This is our national data from the United States, and this comes from a recent publication that was developed through the Heart Failure Society of America that I'm quite involved with, led by Beacon Boskert, looking at heart failure statistics. And there's some beautiful figures that are freely available online, such as these that you can use for the purposes of teaching as well. But as you can see here, in the United States, we surpassed about close to 7 million patients a couple of years ago, and it's estimated that by the end of this decade, we'll be nearing 9 million patients, and this continues to grow. Now, one of the first questions, and I'll ask some questions as we go along to think about, is what is the lifetime risk of developing heart failure? Is this a rare disease, uncommon, or common? And I think hopefully, as you know, it's an incredibly common disorder. This is the lifetime risk of developing heart failure. That is 6 out of 25 women will develop heart failure in their lifetime, and 7 out of 25 men. So about 1 in 4 adults will develop heart failure over the course of their lifetime. This is an extremely common diagnosis and the most common inpatient diagnosis for older patients in the United States. Now, it turns out that there are, like many diseases, there are racial and ethnic disparities in this problem we call heart failure. This is just looking at incidence of heart failure data over 1,000 person years. And you can see that at least Black and Hispanic communities are, in fact, impacted greatly by this disorder, more so than white adults. And then there are other populations, some Asian populations, particularly such as Chinese and Japanese, that have relatively lower rates of heart failure developing over the course of a lifetime. The highest burden that we see in Black adults, particularly in our country, has to do with a higher comorbidity of burden compared with white and Hispanic adults, with increasing risk of diabetes, obesity, hypertension, smoking, and kidney disease, all of which are associated with a risk for developing heart failure and worsening heart failure once the disease develops. About 50% of hospitalized patients in the United States are Black adults, and 50% of hospitalizations occur in zip codes in the lowest quartile of median household income in our country. So there are both socioeconomic and other social determinants of health that impact on the risk of developing heart failure. Now, for most patients, heart failure is a chronic disease, such as COPD or asthma or diabetes, that can and should be well managed. And the good news is, and this would be an entire talk on chronic heart failure, we have multiple medications now for treating patients with heart failure. We now call these the four pillars of care. ARNI, or if you don't have ARNI available, ACE inhibitor, ARBs, beta blockers, spironolactone or eplerenone, and now finerenone, a mineralocorticoid receptor antagonist, and of course the newest medications, the SGLT2 inhibitors that are now approved for the treatment of patients with heart failure. We have a number of devices that have been approved and used over many years, including biventricular pacemakers, defibrillators. Patients with heart failure typically undergo ablation procedures, and then there are catheter-based procedures such as mitral valve repair and tricuspid and aortic valve replacement that can also be important in this patient group. But equally important are lifestyle changes that are shown here, including exercise, stress reduction, and minimization of alcohol use. And then, of course, treating comorbidities. Importantly, nearly 40% of our patients can have diabetes. Significant proportion have undiagnosed sleep apnea, and obesity continues to be a comorbidity that affects the outcome of patients being treated for heart failure. Now, for some patients, heart failure may progress more rapidly. Examples, of course, on the left would be someone presenting with acute myocardial infarction, STEMI, and cardiogenic shock. Patient shown here in the middle, this is a US football player who, as some of you may have heard, had an on-field cardiac arrest, but has recovered and came back to playing in the NFL. And then, of course, younger women during or following pregnancy can develop a particular form of heart failure we call peripartum cardiomyopathy. These are just some examples. Now, it's important as we manage patients with chronic heart failure to be assessing their risk as we take care of them. There are the typical anticipated markers of increased risk I've listed here. So even though we initiate and titrate guideline-directed medical therapy, at some point, if patients get sicker, they become intolerant to this therapy. They can develop frailty, cachexia, worsening renal function, and resistance to diuretics, and recurrent heart failure events, clinical events such as emergency department visits or hospitalizations. And then there are the unexpected events that we also see in our patients. The need, even briefly, for a positive inotrope such as dobutamine to treat them in the hospital. The need for acute mechanical circulatory support such as an intra-aortic balloon pump or newer devices such as an Impella device. The need for renal replacement therapy, or in worst case scenario, intubation and resuscitation. These are all markers of increased risk and should lead to the consideration of advanced therapies that we'll talk about in a second. Well, what is the one-year mortality with advanced heart failure? Now, most patients and family members don't understand how significant their prognosis is. And just to put this in light, if you look at the one-year mortality of patients with advanced heart failure, it's nearly 50%. Most patients, again, are not aware of that. Many physicians aren't aware of that. And look at when you compare that to more common diagnoses. So patients, for example, with an acute MI have a one-year mortality of 20%, following a stroke about 10%, and with the new diagnosis of colon cancer, only 7%. So again, marked disparity in morbidity and mortality rates in patients who carry a diagnosis of heart failure. Well, in the United States, there's significant variability in mortality rates, and this has been shown in countries around the world as well for a number of reasons, as I already alluded to, including social determinants of health, socioeconomic factors, as well as underlying comorbidities. So let's turn our attention now to one of the treatments that we've had available for treating end-stage heart failure for over 50 years. And this story of heart transplantation starts actually in Moscow, Russia in 1958. This is a surgeon by the name of Dr. Demikov, who for many years was performing heterotopic heart transplants in dogs. And many of his dogs were surviving days, weeks, and the longest survived 1 to 2 months. Now, interestingly, most other clinical investigators and innovators around the world didn't even know that this research was taking place was all published in Russian, and it wasn't until really after Dr. Demikov died that people became aware of the groundbreaking surgical techniques that he was developing for organ transplantation. Well, when and where was the first heart transplant performed? And this, of course, is where the international story first began. That, of course, was in Cape Town, South Africa in 1967. And this is not a real photograph. This is actually a photograph of a museum room that's been created in Cape Town, South Africa, dedicated to the first human heart transplantation. And as you can see under the light by the operating room table, that's Dr. Christian Barnard. Christian Barnard performed the first human heart transplantation in 1967, over 50 years ago. And in fact, he received significant acknowledgement for this feat. He was on the cover of many magazines in this country and around the world. Interestingly, he went on to lead a sort of a more interesting life outside of medicine. Many thought that he really, this went to his head, and he was a bit of a playboy as he aged. And we turned our attention back to other really leaders in this field. Now, I will say that in retrospect, the real heroes of Cape Town are these two individuals shown here in this photograph. On the left is a middle-aged gentleman with diabetes and end-stage ischemic cardiomyopathy named Louis Washansky. He was the first patient who received that heart. And on the right is a young woman who donated her heart. She was killed in a motor vehicle accident in the same city at the same time, and her heart was removed in an adjoining operating room and transplanted into this patient. Now, Mr. Washansky lived for about 2.5 to 3 weeks after transplant, but unfortunately, in the setting of aggressive immunosuppression to prevent rejection, he died of infection and pneumonia. Well, who do many consider the father of heart transplantation? And this is where the story comes a bit back to the United States. And that would be this surgeon shown here on the left. This is Norman Shumway at Stanford University. And shown on the right is Dr. Shumway's laboratory, including colleagues that helped him develop really the technique for orthotopic heart transplantation. And actually, Dr. Barnard came and learned the technique with Dr. Shumway in the laboratory before he scooted back to South Africa and performed the first transplant. But Dr. Shumway and smaller groups around the world really took on the mantle of heart transplantation and carried this forward in the late 60s and early 70s. Unfortunately, this was the cover of Life magazine in 1971, which reported on the tragic record of heart transplants. So similar to our first patient, many of the early patients died soon after transplantation, and ethicists, as well as clinicians around the world, called for a moratorium on heart transplantation. They felt that this was not ethical to perform. But really innovators and leaders such as Dr. Shumway and others around the world persisted in this, in their goal to make this a real standard of care for patients with end-stage heart failure. And indeed, it became so. This is a photograph on the cover of a book that was taken off the coast of Maine, a state that I'm from, which is north of Massachusetts in the United States. And this is a young man who, when he was an 11th grader in high school, he came home for Thanksgiving vacation with a cough. And when he went back to school, he developed really advanced heart failure from a dilated cardiomyopathy. It was presumably secondary to a virus. His mother, Victoria Poole, and their family actually took him out to Stanford, and he was one of the first 100 patients who received a heart transplant at Stanford University. And he actually lived for several years following his heart transplantation, showing that, in fact, this could be done and patients could have successful outcomes. Well, what happened in 1982 that led to the proliferation, finally, of both programs performing heart transplantation around the world and the number of patients receiving a heart transplant? And that took place in two places, one in Basel, Switzerland, and one in Pittsburgh, Pennsylvania. So Sandoz Biopharmaceuticals, that was located in Switzerland, partnered with investigative teams around the world, including the team at the University of Pittsburgh, and released a new medication called cyclosporin. And cyclosporin, when added to prednisone and azathioprine or Imuran, led to significant improvement in survival rates. And with that, really the field took off. Now, unfortunately, these medications that we use to prevent rejection do have side effects. One of the things that was quickly noted by these investigators, for example, at Stanford University, is that cyclosporin had acute nephrotoxicity or renal toxicity. This is showing some of the buildup of the debris in the renal tubules on the left. And you can see after 1 year, those patients who received cyclosporin had an increase in their serum creatinine level. And as I'll show you later, chronic kidney disease continues to remain a problem even in the current era. A few years later at UT Southwestern Medical Center in Dallas, it was shown that patients taking cyclosporin on the top here also had increased sympathetic outflow. This is a nerve. A monitor, a needle monitoring a nerve in the leg showing increased sympathetic activity. And we now know that cyclosporin and now tacrolimus, the calcineurin inhibitors, increase adrenergic tone and contribute to hypertension, headaches, and other complications such as tremor, which are also quite common side effects in our patients. Well, here we are today. This is international data. So this is from the International Society for Heart and Lung Transplantation, just looking at why patients in the current era undergo heart transplantation. And you can see about half of the patients are transplanted for non-ischemic forms of cardiomyopathy, about 40% for ischemic cardiomyopathy, and the other 10% are really divided among a number of groups: patients with end-stage hypertrophic cardiomyopathy, valvular heart disease, restrictive cardiomyopathy, and adults with congenital heart failure as well. About 3% of patients worldwide and in this country as well undergo retransplantation. These are typically children and adults who received transplants at a younger age and unfortunately had complications and required a second heart transplant. I've listed here the generally accepted indications for heart transplant, that is, clinical indicators of advanced heart failure that I mentioned earlier. Objective assessment of functional capacity performed on a cardiopulmonary exercise test. Patients with refractory arrhythmias or angina that can't be treated with standard therapies. Certainly patients who developed end-stage heart failure that are dependent on inotropic support or mechanical circulatory support would be candidates for consideration of heart transplantation. And then in general, we try to target patients who do not have severe obesity and who are generally under the age of about 70, but these are relative contraindications or indications. And certainly programs such as ours and others around the world have transplanted patients into their 70s and patients with BMIs of 40 or above with good outcomes in highly selected patients. Now, I'm going to just show you some heart transplant volume data. If I showed you the worldwide data, it would look very similar to this, which is that for a decade or more, the number of heart transplants performed around the world and in our country was relatively flat. So in the US, the volume was about 2,200 transplants per year up to about 10 years ago. But over the last 2 years, there's been a steady increase in transplant volume. And I'll talk a little bit more about why that is. In 2023, 4,500 transplants were performed in the United States, which was a record high. Well, let's talk a little bit about the change in these numbers and what led to this. Now, this varies a bit around the world, but I will give you some insight into why this happened, particularly in the United States. And it turns out, as some of you may be aware, we have problems in this country. And one of the major problems that we have is something called the opioid epidemic. And the opioid epidemic has led to a significant increase in sudden death among younger adults that, although they may have a history of drug use disorder, still they can have very normal organs that can be used for transplantation. And this is an article that was published in 2016 in the New York Times that said the surge in deaths from drug overdoses has become an unexpected lifeline for people waiting for organ transplants, turning tragedy for some into salvation for others. Now, it turns out that there's also geographic distribution of opioid overdose donors in the United States that I've shown here. There are some hotspots in the sort of mid-Atlantic states, including Pennsylvania, shown here in the red. What's important to note is that about 1 in 6 patients or adults who die of a drug overdose are positive for hepatitis C. And for 3 decades, we did not use organs that came from donors that were infected with hepatitis C. But as I think some of you now know, for over a decade now, we have had these incredibly effective medications, the direct acting antivirals, that can actually cure hepatitis C over 2 or 4 week course of simply taking 1 or 2 pills a day. So a few years ago, we did a landmark study here in Boston at the Brigham and Women's Hospital and Harvard Medical School. This is Anne Woolley, shown here on the right, presenting our data in Nice, France, at the International Society for Heart, Lung, and Transplantation meeting, in which we took patients receiving a new heart or new lung transplant from a donor who had active hepatitis C. They were viremic, and we treated those organ recipients with 4 weeks of daily hepatitis C therapy. And what you can see here is that the viral load, the HCV RNA, shown here on the y-axis, which was elevated in every patient as soon as they received the new organ that was infected, by 2 weeks, all these patients had cleared the virus. And this study was published in the New England Journal of Medicine 6 years ago, and really has led to a change in practice around the world. Now, hepatitis C positive organs are routinely used for organ transplantation. As you know, we also recently went through an epidemic with COVID-19 infection. We also have shown that you can use COVID-19 positive donor organs as well in the United States. This is data from a couple of years ago, which we published, again, showing a gradual rise in the number of donors positive for COVID that we were able to use good organs from, and found no significant differences in post-heart transplant outcomes by donor COVID-19 status, including the primary composite of death, graft failure, and retransplant at 90 days. So we can use these higher risk organs from higher risk donors that we previously would not have used. We've also made incredible advances in donor heart preservation and transport, as shown here. So shown on the left is a surgeon carrying what we sometimes refer to as just an igloo cooler or a cooler. And for decades, that's how heart transplants were performed. The surgeon would go to the donor hospital, would take out the donor heart, basically flush it, put it on ice, and carry it to the recipient hospital. This led to at least a limitation, though, in ischemic time of only up to about 4 hours. But now we have the ability, using either temperature controlled transport, shown here in the middle, or actually ex vivo perfusion, where the heart is actually perfused by donor warm blood on a machine during transport, so that hearts can now be transported for much longer distances than we could previously, which allows for much greater equity in organ sharing in our country and in other areas of the world. At the same time, while traditionally donors were not allowed to become donors until they reached brain death, and that was required to be diagnosed by a neurologist or a neurocritical care specialist. So typically donors were donors after brain death. Over the last few years, we've now begun to use organs from donors after circulatory death. So while they're not fully declared brain dead, they have no chance of survival, and they can be essentially organs can be used after essentially life support is withdrawn in the operating room. There's generally a standoff period of 3 to 5 minutes, and then once the patient is declared fully deceased, then the organs can be used successfully. This is just an early pilot study from Duke University in the United States, showing that in small numbers of patients, outcomes with donation after circulatory death are similar to outcomes after donation after brain death. And more recently, in this paper in this study we participated in, that was published in the New England Journal of Medicine 2 years ago, this is a study in which, using that ex vivo perfusion system shown here on the right, the organ care system, 180 patients were transplanted. Half were assigned to the organ care system, and half to really a control. And the primary endpoint of 6-month survival was no different. If anything, it was actually higher in the donation after circulatory death group that was in which the heart was transported using the organ care system. So this has opened up avenues for new donors and as well as longer travel times. Now, it turns out that patients who receive a heart from a donor after circulatory death compared to donor after brain death are at higher risk of what we call primary graft dysfunction. This is defined by the fact that the transplanted organ doesn't function normally within the first 24 to 48 hours, and the patient requires mechanical support such as VA ECMO. But these hearts generally recover quite well, and the outcomes are very similar. And in fact, as programs have become more experienced using donors after circulatory death in the organ care system, is shown here, the rates of both unsuccessful procurement and severe primary graft dysfunction, shown on the left and the right respectively, go down significantly. This is data from another one of the Harvard Medical School teaching hospital, the Massachusetts General Hospital, collaborators of ours just across town, showing their experience, early experience using DCD heart transplantation and the benefits that they've been able to show for their program and for patients. Now, DCD transplants do raise ethical issues. This has been reported on in major newspapers such as the New York Times. This is published in 2023. There are certain ways of restarting the circulation after an organ donor is declared dead that are felt to be ethically not acceptable, where, for example, the carotid arteries are clamped and the heart is actually reperfused in the actual donor's body as opposed to removed and reperfused in the organ care system platform. That process of normothermic regional perfusion is now on hold for these ethical reasons. Well, how long do patients live following heart transplant? Let's look forward. How do our patients do once they successfully received a heart transplant? And this is really worldwide data that I'm showing you here. So 95% of patients are alive at 30 days. 90% of patients are living at 1 year, 75% at 5 years, and 60% at 10 years. The median survival is around 12 years. That means 50% of patients, all comers, will live more than 12 years. And if you look at survival of those patients who make it through the first year, when a lot of complications can occur, those patients have even greater long-term survival. Well, what is the oldest patient living after a heart transplant? Well, this is news, a photograph that was taken in Cambridge, England in 2022. This woman here in the middle was living more than 40 years after a second heart transplant. So Sir Terence English, shown here on the left, performed her first heart transplant in 1982. And Dr. English's colleague, younger colleague, Dr. Stephen Suey, performed her second heart transplant in 2005. So indeed, we have patients in our own program who've been living more than 30 years after a heart transplant. It's really quite remarkable. Well, unfortunately, patients don't all do well after transplant, and I'll just briefly touch on some of the issues that we run into. The first is cardiac allograft rejection, which is most common in the first year. Most of the patients have mild rejection, as shown here on the upper left, that we don't really typically treat. But for those patients who have either moderate rejection, shown on the upper right, or severe rejection, shown in the lower panel, these are types of rejection that we typically treat with either aggressive IV steroids, or for patients with severe rejection, as shown in the bottom, in which the cardiac allograft weakens, we treat these patients with even more aggressive immunosuppressive therapy, including use of a drug called ATG, or anti-thymocyte globulin. Unfortunately, for patients who make it through the first year and don't have further rejection, the problem that we run into late post-transplant is this problem here. It's called cardiac allograft vasculopathy. We used to refer to this as transplant coronary artery disease. It's a very common cause of late allograft failure. And you can see here on the left in this cross section histology from a coronary artery, instead of sort of focal plaque buildup, what you see here is diffuse intimal proliferation of smooth muscle cells. This is really a chronic immune-mediated process. You can think of this as sort of chronic rejection of the coronary arteries. That on the right, when you look at cardiac catheterizations, leads to narrowing and tapering of all the coronary arteries. And ultimately, these patients develop either small or large infarcts, chronic ischemia, and ultimately heart failure. Now, we don't have great treatment for this type of coronary artery disease, cardiac allograft vasculopathy. All of our patients are treated with aspirin and statin drugs to control lipids, but we've also started to use newer agents such as the PCSK9 inhibitors to treat patients with cardiac allograft vasculopathy that leads to, as you know, marked reduction in LDL levels, as shown on the left, and on the right, using optical coherence tomography. In a research study, investigators have been able to show that the intimal thickness can be stabilized with use of this aggressive lipid-lowering therapy. Well, due to many of the medications they take and the fact that these patients tend to be middle-aged and older, other common problems are seen in our heart transplant patients over the first several years, as shown here. So at 5 years, you can see that close to 100% of patients have hypertension. Over 90% of patients are treated for dyslipidemia, a third treated for diabetes, and at least a third of our patients have mild to moderate renal dysfunction, with about 16% having severe renal dysfunction. And in fact, at 10 years, international data shows that 6% of patients are actually on dialysis, and 2% of patients have actually undergone renal transplant. Well, I want to talk a little bit about the future, and I want to come back to Norman Shumway and talk a little bit about what we call xenotransplantation. So if you're not familiar with this term, xenotransplantation is the transplantation of an organ from one species into another species. Well, when Norman Shumway was asked about xenotransplantation, he famously said, "Xenotransplantation is the future and always will be." He wasn't particularly optimistic that this would ever come to fruition, but in fact, it finally has, and I want to give you a sense of where we are. Now, this is not a new idea. This really landmark event occurred, shown here, over 40 years ago at Loma Linda University in California, when Dr. Lee Bailey, shown here on the left, implanted a baboon's heart into baby Faye, shown here on the right, an infant who was born with hypoplastic left heart syndrome and severe heart failure. Now, baby Faye did live for a few weeks, but unfortunately did die of complications related to this first example of xeno heart transplantation. Again, transplanting a heart from one species into another species, that is, a human being. Well, fast forward 40 years, and this landmark event occurred at the University of Maryland, just outside of Washington, D.C. in January 2022. When this team led by Dr. Bartley Griffith, shown here in the operating room, used a genetically engineered pig's heart, so a porcine heart, and implanted it into this man, shown here in the middle, who had end-stage heart failure and unfortunately was not a candidate for typical heart transplantation, and agreed to essentially undergo an experiment and receive this heart from a genetically engineered pig. On the right here is really the science behind this procedure. Dr. Mahudin really led the laboratory investigation into developing the genetic modifications that would need to be made to prevent hyperacute and acute rejection when the pig heart was received in a human body. Shown on the other side is the patient's son. Unfortunately, this patient lived only for 2 or 3 months and ultimately died, but he didn't apparently die of heart rejection. What they think he died from is from what we call a viral infection from the pig heart. So unfortunately, viruses in animals can be transmitted into other types of animals or other species. And that's what happened in this first case. Now, it turns out that the University of Maryland persisted in this and transplanted a second patient about a year later. Unfortunately, this patient also did not survive, and this patient did die of complications related to organ rejection. This is the patient shown here after his transplant with his wife. She said he knew his time with us was short and this was his last chance to do for others. He never imagined he would survive as long as he did or provide as much data to the xenotransplant program. He was a man who was always thinking of others, especially myself and his two sons. So this is a scorecard on xenotransplantation that we put forth several years ago in honor of the 50th anniversary of heart transplantation, just showing some of the advantages, including unlimited organ supply, elective availability, marked expansion, obviously, of the candidate pool, as well as potentials for genetic manipulation and cost savings. But unfortunately, there are a number of disadvantages that are still going to need to be overcome before this becomes a clinical reality, including hyperacute, acute, and chronic rejection, coagulation dysfunction with bleeding and clotting, and as shown in the first case that I showed you at Maryland, transmission of zoonoses or viruses from another species. There's also significant ethical restrictions on primate use that need to be overcome as well. These are just listed some of the key ethical issues here, and I'll let you just read through these carefully. First off, how do we ethically study models in recently deceased patients? When and how do we actually begin trials in living subjects? How do we define success? And most importantly, how can we ensure that the field is adequately regulated so that we promote safety, the best outcomes for our patients and their families, as well as data sharing? Well, what does the future of heart transplantation look like? Well, I'll just end with a couple of quotes. I think many of you are familiar with the British novelist J.K. Rowling, who said, "The consequences of our actions are so complicated, so diverse, that predicting the future is a very difficult business indeed." My favorite quote comes from one of my heroes, that is Mick Jagger from the Rolling Stones, who, if you happen to catch the Academy Awards, actually did come out and present an Academy Award. As you know from one of the Stones' famous songs, you can't always get what you want, but if you try sometimes, well, you might find you get what you need. And that's what we're hoping for and continue to plan for our patients and their families as we move forward. So I want to thank you very much for your attention. It's been a pleasure to be a part of this worldwide seminar. I'll leave this slide up here for a second. There's my email address. If you want to reach out to me with any questions, and I'll stop sharing here, and I'll be happy to try to answer any questions that you might have. Thank you so much for your time.
Great. Thank you so much, Dr. Givertz. That was fantastic and a great look into the perspective and future that we have for heart transplant. At this time, we'll open up the floor to our Q&A. We can start with the Mbingo Hospital.
Dr. Winford?
Yes.
No questions from our side, actually. It was just really fascinating to hear about all of this and just find out the various avenues that have been explored concerning heart transplantation. And we're just really happy and feel blessed that we were here to get to listen and learn from all this. So thank you.
You're very welcome. And, I realize that heart transplantation is still a limited procedure everywhere, both in this country and really around the world. But it continues to move forward. I think really my area of primary interest is in, managing more traditional patients with heart failure. So if there's anyone in the room who has any questions that they'd like to ask me about just patients of theirs that they're taking care of with heart failure or any other heart diseases, I'm happy to try to answer them as well.
We have a silent room. They're all really smiling because it was a fantastic presentation, but they're all really quiet. But really,
That's
thank
fine.
you.
That's fine. No problem. I hope you guys have a great afternoon. Thanks for joining.
One of the risk factors that was not mentioned for heart failure, particularly in Blacks,
Yeah.
is rheumatic heart disease, which
Yeah.
is really common in our context. Now, I'm just curious, have you ever had one of these patients benefit
I have.
from
The reason actually it's interesting you asked me that. The reason I actually became interested and ultimately a career in heart failure was when I was possibly in some of the shoes of your students or trainees. When I was a third year medical student, the first rotation that I actually did in the hospital was at the Veterans Hospital down the street. And it was a general medical service, but this Veterans Hospital was a referral center for heart patients around this area of the country. And the first patient I took care of was a patient who had a history of rheumatic fever and had mixed moderately severe mitral valve disease, as well as some aortic valve disease, and had undergone a surgical procedure and unfortunately had developed significant heart failure and pulmonary hypertension. And it was really taking care of that type of patient that just really I was so passionate about even at a young age. I loved the physical exam findings. I loved the fact that we had therapies that we could institute in the hospital, even including IV diuretics, and the patients could be monitored carefully every day as they lost weight and started to feel better. And then there was really the ambulatory care of those patients that then I became excited about later on in my training. So we don't see a lot of rheumatic heart disease anymore, but there's a large, certainly immigrant population in the United States. Hopefully, and there, and so we do see those patients, certainly not to the degree that you do.
Oh, please, actually, there's a question from one of our faculty here.
Dr. Kinney speaking. Thank you for the presentation. We are just curious to know how you go about the ethical issue around the animals. It's not something that we have as a problem here because we are not implicated in experiments, but we are wondering, yes, what it
Yeah,
takes.
so that's a great question. And in fact, there are ethicists that are working and have been thinking about this for many years as, certainly there's a long history of using animals as really models of human disease. And, I think many, as you know, most of the medical therapies that we have available didn't become available to use in patients, and they were shown to be safe in animal models. Now, it's hard to translate some of those models, for example, in mice or rats to humans. This idea of actually raising animals, including, let's say, a pig, for the purpose specifically for harvesting their organs to use for organ transplantation is a much more really thorny issue that ethicists are dealing with. And as you might imagine, there is the animal rights community that takes great issue to this. But there are others who say that for all the advantages I showed on that scorecard, availability, being able to offer this to a significantly greater number of patients needs to be taken into account. On the other hand, I think the treatment of the animals for the purposes of either research or clinical care also has to be taken seriously. So I'm personally, I would say I'm a little bit conflicted. That's as much as I'll tell you.
Okay, thank you. Yes.
Well, thanks, Dr. Givertz. Again, I think talks like these, I feel like are as important as sort of our day-to-day bread and butter things that we see in different parts of the world as well. Because I think they inspire us. They a lot of our resident colleagues there. Previous program director actually went for a cardiology fellowship over at Aga Khan in Nairobi, and we were able to help support some of that as well, his efforts there. And he hopes to come back and set up a cath lab and at Bingo and so forth. So I think talks like these, I think, are great in terms of inspiring and our next generation there serving Cameroon. And thanks again. And then, as I said, this is gonna be recorded. This has been recorded and will be up live
No problem.
in
And feel free
YouTube.
to, if you ever have an opening, you can invite me back, and I'd be happy to talk about more bread and butter cardiology as well, because it's what I do every day. And in fact, in about an hour, I'll be in clinic, dosing diuretics and beta blockers and
Yeah.
just managing patients, which is what I love to do. So thank you for
Absolutely.
having me.
Well, absolutely. Thanks again. Thanks, residents over in Cameroon, Dr. Shinda. Thank you for joining. And thanks from Nepal. I believe we have colleagues here listening to the webinar from Nepal and India as well. And thanks for joining. Thank you.